Welcome everyone to this exciting webinar on drowning. My name is Cristian Abelairas Gómez. I am Associate Professor at the Faculty of Education Science at the University of Santiago de Compostela, and I am member of the Science and Education Committee on Basic Life Supports. It's an absolute pleasure for me to co-moderate this session with Sander van Goor, co-chair of the same committee, the SEC BLS. We have an amazing panel of three experts, Joost Bierens, Paddy Morgan, and Florian Reizine. All attendees have access to the Q&A box on your Zoom screen. Please feel free to submit any questions for our speakers. We'll allow time for a couple of questions after each presentation, followed by an open discussion at the end of the session. So let's begin with this outstanding panel. Our first speaker is Joost Bierens, who is enjoying a retirement after a life as anesthesiologist and emergency physician with previous academic positions at several universities, contributor of more than 200 research papers on drowning, among them several ERC guidelines. Now is leading the third edition of the Handbook of Drowning, and in 2023 he was appointed as Dean of the International Life-Saving Academy on the International Life-Saving Federation. You may begin, Joost.
Oh, thank you, Cristian. Thank you very much for the extensive introduction, and I think we should move forward right away with the presentation. And on this slide, where you will see a global overview on drowning around the world, and based on the different colors, you can see what the difference in incidences around the world on drowning is. The ones which are blue are the countries which have a low incidence, something around 1 to 2 per 100,000 people, and those areas which are reddish and orange, they have very high incidence, coming up to 5.8 and even to 9 per 100,000 inhabitants in that specific country. And most of all, this is not related to the geographical area, but it's most of all related to the income of the countries, where the low-income countries have a much higher incidence in drowning than the high-income countries. You also see that between 2000 and 2021, the number of drownings, of accidental drowning, reduced with some 20% around the world, but this figure only relates to the accidental drowning. It doesn't include the suicides or the drownings during migrants or floodings or other issues where also drownings occur. One of the things that you should realize if you look to such a picture around the world is that not only the incident differs in many countries, but also that the way drowning happens is very, very different. When you work on a beach, you probably see a completely different situation than one as I do in the Netherlands, where it's quite regular that a car is just tumbling down into a small ditch and only 40 centimeters of water is above the occupant of the car, and he's still dying from drowning. The same can be told about the situation between high and low income countries, where both the knowledge and the swimming skills, but also the rescue and resuscitation issues are completely different from the high income countries, and also the ambulance service and the CPR knowledges. So it's very important to realize for all of this, I think more than 1,400 participants of this webinar of today, that the setting that you know from yourself, in your setting when you talk about drowning, could be completely different from the setting in other parts of the world. And actually that's one of the reasons why there is a saying that all drownings are completely different. And even when all these drownings are completely different, there's still another big difference between the normal cardiac arrest situation, where you have time to see that a person is on the ground getting a cardiac arrest, is laying down or sitting in his chair, and you have time to recognize that and to start your treatment. In drowning, you don't have that much time. In general, people disappear underwater within 2 minutes. There is no typical sign for that. There is no screaming, no yelling or raising of arms. And if there is a typical behavior, you actually need to know what you should see to recognize it. Something like the backward water milling or the instinctive drowning response can happen in maybe 20-30% of the cases. But in very many other situations, the drowning will be unnoticed by bystanders. So the bystander in a drowning situation is most of all a person seeing that somebody is going to be rescued, but not the situation that the actual drowning or the cardiac arrest situation is present. So what is then happening when a person disappears under the water? And I'm afraid that I have to go back to people living in the previous century and died in the beginning of this century, like Jerome Model and Peter Safar, who were at that time in the 50s and 60s and 70s of the previous century, the people who were indeed able to do research on the drowning mechanism, the drowning pathophysiology and physiology. Jerome Model put a lot of effort in understanding the role of electrolytes and the volume of water aspirated in the water, while Peter Safar was doing a lot of research on hypothermia and brain damage after in resuscitation settings, but also had a great interest at that time in drowning-related research. And two of their quotes are, one is that each drowning is different, and the other one is that we have to save the hearts that are too good to die. And I think this is certainly true for a drowning situation. And actually, there is a lot of different terminology around drowning that might be very confusing. A while ago, we did a review on the physiology of drowning. We fought 14 different mechanisms. And if you look to that, then actually the mechanism like laryngospasm, diving reflex, autonomic conflict, actually they're all concepts. We never can prove that they are there. We cannot test them. We don't know if it happened when somebody is taken out of the water, but it gives an explanation for some of the clinical signs that we see in some drowning victims. But the actual fact, if it has been there, it's never been proven. Of course, the water in the lungs and water in the stomach is something that clinically is very visible. But even if you want to really go in depth in understanding the pathophysiological mechanisms, even at a cellular level, there's very little research being done on that. And only recently, some Chinese and Japanese studies really went into depth in what is happening in the lungs of a person who is drowned. Of course, the issue of electrolytes is well studied, and we know it's not very important. On the other side, hypothermia is very, very well studied, and Paddy will go tell us a little bit more about that. And also at my final presentation will say the final slide in my presentation will say something about that. And even hydrostatic pressure gradient, which is a mechanism that can be related to drowning and is actually easily be studied, still has a lot of open questions about what actually it does in the mechanism of drowning of a person. So actually it all comes down to one mechanism, to one common ground. And that is that it's a respiratory impairment, it's an hypoxic problem. And those familiar, of course, to the issue of drowning, they know this definition, that drowning is not a status, it's not a solid moment, it's a process of experiencing a respiratory impairment from submersion or immersion in liquid. And if this process continues to move forward, then at a certain moment the person will die and you have a fatal drowning. And if the person is taken out of the water in time or the resuscitation is successful, then you have a non-fatal drowning. The question is always, when does now the drowning starts? When somebody is taken out of the water. And for that we have defined a cutoff point is that says that when somebody is really involuntarily distressing and coughing, so he cannot control his coughing, that means that the respiratory impairment is there, that the respiratory system is affected, and from that moment onwards we call somebody a drowned person. So somebody taken out of the water who is not coughing is a person rescued from the water, but it's not a drowned person. And I think for statistics and epidemiological studies and also resuscitation studies, this is very important to understand. Then once the person is surviving and there is not fatal, then it can be without complication, and that's fine, and sometimes with complications. And most of the complications At the short term are pulmonary problems, and on the long run, the neurological complications. And the pulmonary complications will be addressed later on this presentation. So what is relevant in drowning always to realize is that you talk about submersion, which is when the mouth of the person is underwater, you don't get fresh air, and the other situation, immersion, when the head remains above the water, the person can continue to breathe. The problem is here hypothermia. When you go to the first situation, the submersion situation, the actual problem takes place in the cells. I mean, the mechanism of a cell is relatively simple. You have oxygen, you have got glucose, these all both enter the cell, and the cell does what it needs to do. When there is no oxygen in the cell, or the temperature in the cell is not adequate, the cell doesn't function and stops working and get damaged and disintegrates after a while. And the most sensible cells for that are the brains and the heart. So in a drowning situation, it's the lack of oxygen that at a certain stage takes care of the heart to stop. The heart itself has been healthy for all the time. In itself, there is no problem with the heart, but it's just because the function of the heart is unable to perform because there is no oxygen there. It can be compared with a car where there is no petrol in, it just doesn't drive. You need to fill in the petrol, and then you can start the car all over again. And this is the essence why in drowning it's so important to do the resuscitation with ventilation first on that one. Then when you go to the other situation, the hypothermia, this is always a very disturbing part of the drowning in the drowning mechanism. And most of all, this is because there are 4 different ways that hypothermia can affect in a drowning situation. One is that if a person is falling in very cold water, he or she can have a cold shock, which result in immediate disappearing and staying under the water. So it's an acute drowning. If somebody stays in the water for a more prolonged period of time, the person becomes hypotherm, and as one of the results of the becoming hypothermia, he or she is unable to swim, and that could be a reason to drown. At the other side, when hypothermia is progressing and the person disappears then underwater, then sometimes, but really in exceptional situations, very long submersion time is possible to be survived. And then finally, if a person really is cold, he is dead and he cannot be rewarmed. So it's always very difficult in drowning studies to really see what has been the role of temperature, both of the water and the temperature of the body of the drowned person in resuscitation studies, because it can have very different effects. I had only 10 minutes to discuss something about the pathophysiology of drowning. I can talk about it for more than 2 hours, but I hope that in these 10 minutes you had a broad overview on the topic. If there's any questions, then you can ask them now or maybe later. Thank you.
Thank you very much, Joost, for this wonderful presentation. We have no questions from the audience right now, so I think we can carry on with the presentations and encourage the audience to leave all the questions that they consider and discuss with the experts. Now that we've seen the physiological foundations from Joost, let's move to the practical reality of rescue and first response with Paddy Morgan, who is an aesthetic consultant in South Mid Hospital, and he has contributed to the ILCOR evidence reviews in relation to drowning. He is member of the ILS Medical Advisory Committee and the International Drowning Research Alliance. His research is associated with the Extreme Environment Laboratory at the University of Portsmouth in the UK. Over to you, Paddy.
We're off. Good evening, all. Thank you very much to the European Resuscitation Council for the invitation to speak. Joost has set the scene beautifully, and what I'm hoping to do now is do a very rapid run through of some quite complex things, but hopefully come back to exactly where we are and what we're doing. So the summary of this entire presentation, I could probably stop now, is that air goes in and out, blood goes round and round. If it's not happening, make it happen. And in drowning, that's often the case, that it's not happening. We need to make it so. So my first kind of plea is that if you're a non-clinical responder, you do not have a duty to respond, don't panic about doing something specific for drowning. Stay safe, do your chest compressions, and if you remember to do ventilations, fantastic. But if we make it a little bit more complex, as alluded to, part of my role is with helicopter emergency medical systems, and a call comes in, 32-year-old female in the harbour, unconscious. That's the go. This is an urgent tasking where airframes are appropriate because of the complex skills that are going to come in next potentially. But this is my beach. This is the beach I looked after for many years as I went through university. And never a truer word was said than cell team casualty. That's your priority. We lost at least 2 people per year who went after dogs or children because they didn't know how to. So if you know how to rescue, go for it. If you don't, sit tight and use alternative methods. This is what we'd call a hierarchy of rescue within search and rescue and the lifeguarding world. But I would honestly say, ignore the last 3. If you don't have a duty to respond, you don't have that additional training, signal for help, signal, shout at them, reach with something, staying on the bank, and throw them something to float with. That's the key to survival on this. Stay afloat and keep the airway clear. So we've got to scene in our helicopter, and like any road traffic collision, a drowning event is complex. People don't drown just because they can't swim. They drown for other reasons. They've had a cardiac arrest from a heart attack, myocardial infarction. They've had a stroke, an epileptic seizure, low glucose. But also, just like a road traffic collision, you'll have multiple responders there, fire service, ambulance, search and rescue personnel. It's complex, and you very quickly have to get on top of things. So, of course, in our case, you do, and you've told us 4 casualties. One's in the car shouting, one's self-rescued, one's inside the car and underwater, one's been recovered to the bank, advanced life support is going on, and the initial rhythm is ventricular fibrillation. And the incident commander looks to you as the first responder there to say, how long should we carry on, Doc? What do you want to do? Or we can break this down into self-rescue shouting as dry, they're out of the water, immersed, submerged, and the last 2 will be immersed, but they may have been submerged, and we don't know at that stage. And actually, the one that's having resuscitation ongoing, it's key to know submersion times, as Joost alluded to, that it's the hypoxic dose. How long have they been underwater without oxygen determines their survivability. But you may be that the dry one has actually aspirated some water. So how can we determine that actually this person needs help? Well, as we discussed, Joost said, the immersed person may be cold, maybe hypoxic, unlikely. If you're subsurface, you are hypoxic, and you may or may not be cold depending on how quickly it's happened. But the number of times I've been to households where there's a bath and there's a child face down, that's also submersion. It's about where that airway sits in relation to the water. So what about this person? Well, the dry person who's out of the water, if they've got a cough, but there's no foam, and it looks like they're spit at the side of the mouth, they can have delayed self-presentation, a bit like being sent home. And some of the stuff done by Ogilvy Tom and his colleagues have looked at this in the emergency department. The same happens in the pre-hospital phase. Normal respiratory rate, normal oxygen levels, they're alert, there's nothing to find on the chest, and they aren't requiring supplemental oxygen. They can be sent home. And their study actually had 0 participants came back having had those discharge criteria. For all the others, well, you're drifting now into critical care, into resuscitation. They all need hospital admission. They all need oxygen therapy and consider emergency anesthesia. Now, emergency anesthesia, in 10 minutes, I can't go into the details of the hows, the whys, the wherefores. But the one thing I would say is consider it, for those that are trained to do so, consider it like a head injury. So, or Goldilocks and the 3 bears. This is some oxygen, but not too much, not too little. 2 seconds. Do me a favor. Not enough CO2, not too much, not too little. Glucose, not too much, not too little. For those that have gone into cardiac arrest, and this is one of the ones we use with His Majesty's Coast Guard as our guidance, and you can see that almost the resuscitation of an adult is the same as a child in that you have 5 initial breaths. The difference being that in an adult, you stick then to your normal protocols, 32 compressions. Connect your AED if it's available, but don't worry about the AED. Do prioritize that oxygen first. Spinal injuries, it's less than 0.05%, and you've got to have a mechanism that fits with it. So diving headfirst into the shallow end of a swimming pool, possible. Being dumped by a 6-foot surf on a shore break, possible. Falling off a boat at low speed, falling into a garden pond at low speed, less likely to have a spinal injury. And the final thing to note here is that when you are starting to apply that oxygen, consider increasing your ventilatory pressures slowly and gradually. Because if you go too hard, too fast, too soon, there'll be cardiovascular system collapse, gastric insufflation, and they're a problem for us. They're a problem for our resuscitation. It prevents that preload to the heart, and they will have collapse. Consider early ECPR. And talking about ECPR, the phrase that will be coming through in the 2025 guidelines is if no response to initial resuscitation. And this is a recurring theme here that if initial oxygenation and chest compressions do not work, time to think of what's next. And the key predictors, if you go towards ECPR, is how long have they been submersed? Is there any lethal injury? How long have they had active resuscitation? Electrical activity is good. A temperature greater than 15, great, it's got to be a core temperature. And this starts to drift outside of most persons' response capability. Again, potassiums, some critical care teams will have point of care testing for blood gases and may be able to test this. But in most circumstances, that isn't going to be available in a timely way. You've got to stay within your own local systems. And talking of local systems, how do we get them in? What about, we've rescued them on a lifeboat. Can we do resuscitation? Well, as you can see, there's a lifeboat crew at the bottom right-hand corner of that boat there. And there's a person that he's not resuscitating. And the reason he's not resuscitating is he's trying to keep that person on the vessel. So not appropriate to try resuscitation here. But lower speeds, more stable vessels, absolutely. If you're trained to do so, do attend chest compressions and ventilations as you go. What about airway management? Always controversial. I always get asked this in the UK because intubation of the trachea is not a skill that all paramedics now do. The study, as you can see there, I won't read the details, but they showed, yes, do it where you're competent to do so, but there's no association with favourable outcomes and no difference in long-term survival if you're intubated or if a supraglottic airway is used. But of course, when you drill down to the details, the key factor is that only the ones that didn't have that initial response to resuscitation, had the expert teams arrived, then had a tracheal tube placed. And Joost mentioned cold. The current guidance is still consistent with that in 2015. Duration less than 10 minutes, high chance of survival. Over 25 minutes, invariably, there are no survivors. But if you have icy cold water, it may prolong that window. And that's due to a massive inhalation of water, lots of swallowing of water during the drowning process. If, and there's lots of ifs here, selective brain cooling, but it's rapid, pre-cardiac arrest, pre-hypoxia, maybe. And I could recommend this study by Tipton and Frank Golden, where they looked at case studies where there were survivors. And if you go below 6 degrees, you do get a few. But the key bits, however, are the timings are crucial. First responder on scene, any potential air pockets, that's an immersion, not submersion. The water temperature as mentioned, and salinity. So to date, and we've just reviewed this, there are no survivors in salt water beyond 25, 30 minutes, submersion. And again, early referral to extracorporeal life support. In the UK, we've put together a submerged person tool which addresses this. And one of the key things of this in terms of logistics is don't make a decision in isolation. Get together, and I won't go through the details, but get together with those others on scene who may have information for you and work through. 30 minutes is your cutoff. You've got to have a reason to go beyond that to risk rescuers going from 30 to 60. So in summary, I appreciate it's a rapid run through. Self-team casualty. If you're not safe, you're no good to your team, you're no good to your casualty. Oxygen is key. 5 initial inflations if you have a due to respond, or if you remember, submersion versus immersion is one of the key concepts. And you can tell that by both Joost and I repeating it. And think of them like a wet head injury when you go to the more complex level. Not too much, not too little, just right. Air goes in and out, blood goes round and round. Make it so. Thank you.
Thank you very much, Paddy Morgan, for this great presentation. We have a couple of minutes for some questions in the Q&A box, and we have a couple of them related to the hypothermia. Joost, is for you, what is the role of hypothermia in the heart function? And we have another one, why patients after drowning will not warm up? What are the physiological causes?
Okay, thank you for both questions. When my interpretation of the questions is correct, is what the hypothermia does on the heart. This is again to be explained very good by just thinking about a cell. This cell where the oxygen is coming in and the glucose is coming in, it does what it needs to do at the moment that it has the right temperature. And a lowering temperature of a cell is making the cell functioning less good. And as well as getting less oxygen to a cell makes that the heart cell doesn't work well. It also means that the lower temperature doesn't make the heart cell doing well. So what you'll see is that gradually the heart cell will become and will work slower and slower, and also the conduction system will work less and less. So what you initially will see is a slower heart rate with a slower pump function. Finally resulted in a functional arrest of the heart, but still some electric activity. And finally, you will get into a ventricular fibrillation situation when you talk only about hypothermia. So an hypothermia process from normal temperature to hypothermia passes a period of ventricular fibrillation, which is related to the cold temperature of the heart itself. This is completely opposite of the situation of somebody who has become hypoxic. In an hypoxic situation, the heart is also slowing down, but it doesn't get into a ventricular fibrillation situation. It goes from a low heart rhythm into gradually in a bradycardia and then in an arrest situation. And this is also the reason why an AED in drowning very often is not needed, because there is no VF, and that's my personal opinion. I think very often there is a VF seen in a drowned person because one started to do CPR in the person that still had circulation. So I think that was the answer to the first question. And at my age, I forgot the second question. What was that?
The second question was about the difficulty of the drowning patient to warm up.
Yes, because you need circulation to heat the body up. Of course, you can heat up anything, like you can also heat up your food, but in a normal situation, in a clinical situation, you need circulation for heating up a body. So one of the signs of a person really being dead is that it's impossible to warm a patient up under normal warming up therapies, because the amount of calories that you put in a person in that way with circulation should be sufficient to warm a patient up. But if there's no circulation, all the heat will go through conduction, and for that you need much more calories and energy than you normally give in a clinical treatment situation. I hope that I explained this clear enough. If not, then please give feedback on this.
Thank you very much, Joost, for these clear answers on a topic that could be addressed in a whole webinar, right? The next one is for Paddy Morgan, is about the 6 levels of the categorization of the drowning.
Thank you. I'll first caveat by saying it would be wrong of me to critique an institution's 6 classifications without seeing the full details. Those fieldsmen over in South America had actually classified drowning into the classic 6 categories, which is incredibly useful for research, but ultimately is the responder, which is where whilst I sit at a strategic level in the UK and I organise and train courses, as a responder, however, it comes down to your basics. If you have got the presence of foam, the reason to document that is that's a reason for hospital admission. If you've got the presence of a little foam or a lot of foam, to me, that doesn't make a difference in what my initial actions are going to be. It's still going to be oxygen, maybe ventilatory support if required, but they're all going to go to hospital. The little or a lot of foam comes down the line. And one of the criticisms of David's original paper, I won't comment specifically on this institution, is that when you've been thrashed around in the surf, you may have had a lot of foam, but you haven't now because it's been washed off because you're still in the water. The last couple of victims I brought out of the water where they were submerged, there was no foam, and yet they had a significant injury following their drowning event. So in my mind, I would have to look at that in more detail, but the key things are going to be foam, that's hospital, probably oxygen, probably ventilatory support, absence of a pulse. I would advise against in the initial phases because invariably these individuals are cold. You can't detect pulses very well, which is why the Resuscitation Council guidelines for detection at the lifeguard level, where they're not healthcare professionals, is absence of signs of circulation. And even for those with healthcare professional backgrounds, we still would look for lack of signs of circulation, so no breathing on all the rest. Again, that will be outside the scope. So that's where I'd sit, but that's probably because I'm a simpleton.
Thank you so much, Paddy, for your response. Now it's time to move on to the next speaker. After understanding the field's challenge, the next speaker will now guide us into the ICU setting, where prognosis becomes critical and sometimes uncertain. The next speaker is Florian Reizine, medical doctor working in the intensive care unit in France, PhD in immunology, and have been working on drowning since 2019 with contributions regarding respiratory management and difference between fresh or salt water, that we have a couple of questions on this regard. In particular, as part of a multi-center cohort of patients admitted to the intensive care, he's presenting the DACA score. The floor is yours, Florian.
Okay, thank you. Thank you very much. So first of all, I'd like to thank the organization committee for this invitation, as I'm very pleased to present a new prognostic tool for drowning-associated cardiac arrest. So as discussed previously, drowning is the leading cause of unintentional death worldwide, with an incidence that is likely underestimated, especially in low-income countries. Clinically, drowning can lead to acute respiratory failure or cardiac arrest, often requiring ICU admission. The key mechanism of the drowning process involves aspiration of water leading to acute lung injury. This triggers hypoxemia and may result in cardiac arrest if not promptly managed. Different clinical pictures can be present in patients after drowning, and the severity has been classified according to this clinical characteristic. Nonetheless, there is a non-linear association between this classification and patient outcome, since day 30 mortality was almost only observed in patients with grade 6 drowning. Logically, the prognosis in drowning patients is mainly linked to submersion time. In addition, severity at ICU admission, along with neurological impairment, were also found to be key prognostic factors. Moreover, drowning is often complicated by pneumonia, especially in ICU patients, with implication in patient prognosis, particularly for microbiologically proven pneumonia, as we showed in this article that aim to investigate the incidence and impacts of drowning-associated pneumonia. Furthermore, in the same cohort of patients, we showed that the presence of initial cardiac arrest at presentation is a major prognostic factor. Another important element is whether the cardiac arrest was witnessed, as witness events have better prognosis due to earlier intervention. Therefore, we aim to develop a scoring system for DACA patients through the inclusion of patients experiencing DACA from our initial cohort. 103 patients, of those almost half died within 28 days after ICU admission. We first assessed variables associated with death by univariable and multivariable analysis. Then we included variables that were independent risk factors and used the beta estimates to define the scoring system, with different points depending on the beta estimates. The DACA score shows good performances with an IUC of 0.91 in the development cohort and the best threshold at 4 points, with sensitivity reaching 92% and a specificity of 82%. We also assessed the performance of our score in a validation cohort of 81 patients and found almost similar IUC with an IUC of 0.82. In terms of prognosis, the mortality rate runs from 2.8% in patients with DACA score at 0 to 97.2% in patients with 7 points. So such difference, so to go further, it seems that DACA may be different from other classical causes of cardiac arrest, with, for instance, a lower mortality rate that could be explained by the reversibility of DACA mechanism. Such a difference may deserve a dedicated scoring system. Goals of a scoring system in this setting is to help clinicians in identifying patients that would benefit from ICU with support decision-making in ICU patients. Nonetheless, the limitation of this score must be acknowledged. Firstly, predictive scores are not absolute, and management of patients may be partially guided by their result, but should not be completely guided by these results. Persistent confounders make it hard to draw definitive conclusions from this score. Finally, this score was developed in ICU patients, questioning its validity for ED patients. To conclude, we saw that there are special features of DACA, and there is maybe a need for a dedicated scoring system. Our scoring system seems simple and reliable, with only 4 variables used. That was built on an ICU population with any limitation of a scoring system to give decision at the bedside. It may help clinician decision, but not replace them. Finally, the DACA score is one tool among many, and we need a multimodal approach for the prognosis of our patients. And the best strategy of drowning is its prevention. Thank you for your attention.
Thank you so much, Florian, for this insightful presentation. We have several questions for our panel. Thank you very much to all the 3 speakers for these clear and complementary presentations. We've seen how drowning is not just a single event, but a complex and dynamic process. We have an interesting question. I think many people have this doubt about the outcomes of the likely difference in the outcomes between drowning in salty water and fresh water.
Okay, thank you very much for this question. It's quite hard to respond because pathophysiology studies on water salinity, on the effects on lung injury are not very clear. We did not evidence any difference between salt water on fresh water on lung injury. Firstly, yes, that's true that we evidence, and we were not the first because some other evidence also was impact in freshwater drowning. I do believe that such a worse impact may be related to the setting of drowning. In saltwater, drownings are mainly during hot season with lifeguards, and so I think that drowning in this setting are more often witnessed, and then CPR may be initiated more promptly. So that's a point, among other, that could help explaining why the prognosis of freshwater drowning are so bad, so worse, as compared to saltwater drowning. And maybe the other speaker may have other explanation.
No, I completely agree with you, Florian, that the overall the physiological mechanism at the level of the lung is at the end more or less similar, although some research from Japan and China shows that at the cellular level, and then we talk about aquaporins and mediators and things like that, there is still a different mechanism between salt and fresh water, but at the end it doesn't have any clinical implications. What I think is a more interesting question is why is the ARDS after drowning more quickly resolved than an ARDS after multi-organ failure, and what is the differences on that level? But that's maybe a very academic question.
Thank you, Joost and Florian. The problem that we have with drowning is we have many variables that have an influence in the prognosis. So sometimes the temperature of the water, the time, the submersion time, the bystander CPR. And regarding that, we have another question, for example, about hypothermia. The question is if hypothermia could preserve life in the drowning patient.
So you're talking about the hypothermia, maybe just, but in our theory, I do believe that hypothermia may also be the weakness of a long submersion time. And that's right that studies in ICU patients showed, or some of the studies in ICU patients for cardiac arrest showed that hypothermia may be good for no prognosis with the theoretical beneficial effect of hypothermia in neurons. Nonetheless, here I think that hypothermia is more related to the duration of drowning, and so that's why it's related with or is linked to what prognosis.
Thank you, Florian. I meant that if in some cases the hypothermia of the patient can be a protector on the prognosis of the patient. For example, drowning in icy water. Yes, Paddy?
Cristian, I can come in on that one. If you go back to a very simplistic model of drowning, and appreciating it is complex, but if you look at the duration and amount of hypoxia, that's a key thing. And then it's almost a multiplication factor with then the protection of the cold. So as an example, if you go into 12-degree water, 12-degree centigrade water, the human body won't cool down to hypothermic levels if you're still active and moving for at least an hour minimum. And that's been shown numerous times in the physiology. But of course, if you're a child where you have a larger surface area to body mass ratio, you will cool quicker. And the best analogy is if you had 80 kilos worth of steak and you took it out of a warm oven at 37.5 degrees centigrade and then put it into the freezer, the inside of that steak will still be warm. But if you rapidly cool or you cool before your cardiac arrest, and that therein's the distinction. So the scenario being an immersion, you're hypothermic, then you have your cardiac arrest because you submerge, your hypoxic insult. When you're hypothermic, then you have the insult. Your brain doesn't need as much oxygen. And we know that from a lot of the anesthetic studies around hypothermic cardiac arrest, induced cardiac arrest in cardiac surgery and in neurosurgery and the like. But of course, ultimately, the human body doesn't cool down quickly enough in most water. And that's where that 6-degree cutoff comes, that you can, below 6 degrees centigrade water, cool down quickly enough. And that's partly because many drowning victims will actually swallow lots of amounts of water. But generally, you cool down because everything's stopped and you're in cardiac arrest. It's not protective in majority of circumstances. Although I've just come back from Sweden where it's very cold and there is potentially some there.
Thank you, Paddy. And Cristian, if I look into all the questions, I see a lot of questions about ventilation and remarks that ventilation is key in drowning. But several questions said, okay, the performance on manual ventilation skills, both in BLS teams, but also in ALS teams, is quite often inadequate. And there are a lot of questions about what concrete steps can or should we take to increase performance, and then specifically in relation to probably the use of ventilation feedback devices to incorporate that in training. Do you have any idea or position about that, Paddy, or maybe Joost, or maybe first Paddy and then Joost? Is that okay?
Yeah, you're absolutely right. When you go to the literature, the performance of non-healthcare professionals compared to the healthcare professional, it is a poor performance with standard bag valve mask ventilation. Even though in healthcare professionals, when you compare your person who is regularly trained and competent on human beings, not just on mannequins, they perform better. And part of the challenge in training is that the mannequins are a fixed facial shape, form, and density. And so, and even with feedback mechanisms, with feedback ventilation trainers, the face itself is fixed. And so you don't learn the nuances around holding the mask on. And that's where the transition to things such as supraglottic airway devices, some of the, not the first generation, they tended to float around, but the later generations are easier to use and can be used successfully. And then, as you say, escalating up towards intubation, but intubation is very much a core skill. That's where I'd sit, but I'll be very interested to hear Joost, because he's actually done some work in this area, I believe, haven't you, Joost?
Yeah, that's right. At least I'm very interested in the area, and I cannot really look into the future. But I've been talking to many people around this typical subject, and it's one of the nice paradoxes when you talk to people around this is that you hear from people who have been working with ventilation equipment after a certain period of time. They say it doesn't work, we want to stop with it. While other people say, yeah, we really want to do it because there had so many advantages also when you use ventilation on a rescue boat, or related to infection, or all the vomit and all the dirty stuff around resuscitation. So actually at this moment we don't know. While at the same time, the use of equipment in the maritime health sector, so on board of ships and professional ships, is something that is part of that training. That's an area that we're not very much familiar with. But the crew members of ships, just commercial ships, fishing boats, cruise ships, they have to learn ventilation with equipment. And their trainers in these circumstances, they say that the people that they train are very well able to do so, even if they have a rehearsal training after 3 years, which is formally, that they still are able to do that. So it's absolutely an area of further research to do. Certainly within the perspective, if we get another COVID or other infection in the future, where mouth-to-mouth ventilation, which is really essential in drowning, is maybe not possible. So this is really an area that needs more investigation. And those people who are able to do that, I would really applaud when they're able to do that.
Thank you, Joost and Paddy, for answering these questions. And one question from my side is also, there is also a debate about the 5 rescue breaths. Do it or do it not? And if you see the performance and actually the low performance probably in ventilation, could that be an argument to skip back to one algorithm? You know, as a co-chair for BLS, that's from an educational point of view in my interest, not from a medical perspective, but the combination will improve survival. So maybe, Joost?
Yes, I know that there is a debate around that, and people who, for educational purposes, want to have it identical. What I've been trying to explain in my presentation is that the bottom line of drowning is that a person has no oxygen at all. So when you use the normal standard CPR, starting with cardiac compression, you actually repeat the dying process. You circulate blood without any oxygen, and that's not beneficial. Actually, we know that if you continue doing that, it has an even a bad effect. The big difference between a normal cardiac arrest is that when somebody gets a cardiac arrest, the full body is still the body is still full of oxygen. There's oxygen in the lungs, there's oxygen in the blood, there's oxygen in the cells. So when you only do the compression at that moment, that there's a huge amount of oxygen reserve in the body. So you really have quite a lot of time to use that oxygen. In drowning, you don't have that oxygen. There is no oxygen again. And it's absolutely true that sometimes ventilation can be difficult in drowning because of the high air resistance. But this is also a matter of acknowledging this, and don't get in panic, and just keep trying, because most of the time after 3 or 4 ventilations in drowning, the ventilation goes much easier. There's another reason why maybe ventilation first remains relevant. It's because some of these drowning victims will still have cardiac activities. And just by the impact of the ventilation and by the stimulus of the ventilation, you will see signs of life, and you know that you don't have to perform cardiac compressions. But I'm very interested in other opinions around this, because this is always a very nice discussion item in this area.
And that's why I'm very happy with your clarification, Joost. Thank you for that. Any other opinions about this position, Paddy, Florian, or Cristian?
My opinion is I agree with Joost. If you remember to do the 5 ventilations, there is significant benefit because we know that if you have respiratory arrest only, so not cardiac arrest, your chances of survival are greater than 90%, and survival is a good neurological outcome. So those 5 initial ventilations can genuinely be life-saving. And I agree with everything Joost has just said.
Okay, thank you, Paddy. Maybe back to Cristian.
Okay, Joost, Paddy, and Florian. Before close the webinar, we wanted to send you an open question for all of you. And based on your experience, what is the most common misconception clinicians or rescuers have about drowning? What do you think about this?
This is a question to each of us?
Yeah.
Wow.
I'll be short and sweet on mine. The commonest misconception I have is that everybody who's had a drowning event has extended survival because they're cold. And most people ignore the fact it's a hypoxic event. If it was a hanging hypoxic event, they would stop advanced life support after 30 minutes where the rhythm is asystole. And yet in drowning, they fight for longer. My concern with that is, in fighting for longer, what risk is that to the rescuer? What risk is that to the responder? Because ultimately that brain is dead. However, they've started and they've given it a go, so that actually makes me very happy. That's the commonest misconception I have.
Yeah, for me, the misconception is actually the question that you just raised about why should we only have one way of doing the resuscitation on everybody? And I completely understand that from all the resuscitations, maybe 1 or 2% is drowning and the rest is not drowning. But it's still a substantial group all over the world, young people in circumstances where a good resuscitation gives higher survival chances. And one of the problems we have as researchers in this field is that we are dealing with a much more complex situation. If you have a primary cardiac arrest situation, it's very clear. You have either a ventricular fibrillation or you don't have a ventricular fibrillation. If you have a ventricular fibrillation, you either use an AED or you don't use an AED. If you use an AED, it works or it doesn't work. And if it works, you either have restoration of circulation or not. In drowning, it's a much more gradual situation. You can have 5% oxygen in your body, you can have 10% oxygen, you can have 100% oxygen in the body. And the heart could have stopped or it's still working. So it's much more complex to prove what the role of oxygen in this situation is, because it's not every time a go, no go moment, it's every time you have a bandwidth of between 1 and 100%, and every step you make has this difference between 1 and 100%. So research-wise, it's very difficult to prove what is best for it. And of course, that's something that we have to live with, and that no more research is needed to try to understand this better. But I think the biggest misconception is trying to have one way of performing resuscitation in both situations.
Well, thank you, Joost, for clarifying and emphasizing on that. Again, that's always the doubt in educational, between medical educational, etc. Thank you.
So for me, the most important misconception is more at the ICU level is the underestimation of the incidence of drowning-associated pneumonia, particularly in seawater patients, and some of the microorganisms recovered from respiratory samples are not so typical and that might deserve special antibiotics. So I believe that clinicians should perform more oftenly respiratory sample for those patients, notably to target Aeromonas or Pseudomonas aeruginosa microorganism. That's all.
Thank you so much, Florian. I think we can now close the session, but let's go through a brief wrap up and some key take-home messages. I think that from Joost, we learned the physiological basis of drowning and why each drowning is different. Paddy then brought us to the front line, showing the operational and clinical challenges of rescue and early management. And Florian closed the loop with a structured approach to prognosis in the ICU, especially with the DACA score. And from this overall summary, we can extract a few key points to take home. Taken together, these talks remind us that drowning is not a single moment, but a chain of events from water to ICU, where time, teamwork, and tailored decisions make the difference. If there's one clear takeaway, it's that early intervention and integrated care across all phases are key to improving outcomes. And while this webinar has focused on pathophysiology and intervention, we should always keep in mind that the most effective way to reduce drowning mortality is, and will always be, prevention. I would like to sincerely thank our three speakers, Joost, Paddy, and Florian, for their excellent contributions. A special thanks as well to Sander van Goor for co-moderating this webinar and to the ERC for organizing it. And of course, many thanks to all the staff who made this session possible, especially Tatiana Piniger for her support and coordination throughout. Thank you all for joining us today. Bye.